Alright, welcome back to Chapter 21, Anaphylactic Reactions. Today we'll be talking about allergic and anaphylactic reactions, the pathophysiology of allergic reaction, pathophysiology of anaphylactic reaction, assessment-based approach to anaphylactic reaction, assessment and care, epinephrine, and then our summary. Case study intro: EMTs Luke Boyce and Joy Dunn arrive at Armstrong Elementary School for a report of an allergic reaction. 6-year-old Jessie Mendoza began having difficulty breathing, with weakness and a rash within a few minutes of accidentally being exposed to peanuts, to which he has a known allergy. The EMTs see a young boy sitting in the nurse's office with swelling of his lips, and they can hear wheezing without a stethoscope. What level of concern should the EMTs have based on their general impression? What is going on in the patient's body to cause his signs and symptoms? What steps should be considered in formulating a treatment plan for this patient? Again, I encourage you to pause this video, write down these questions so you can answer them in the future as we go along. Okay, an allergic reaction is a hypersensitivity reaction. An anaphylactic reaction, anaphylaxis, is a severe life-threatening allergic reaction. A delay in treatment can result in death. The immune system responds to foreign substances called antigens. Allergens are a type of antigen that can provoke a reaction in some people. The response of the immune system upon exposure to an antigen is to produce antibodies. This immune response typically occurs with little or no allergic reaction. The body can produce immunoglobulin E, or IgE, in response to allergens. When IgE encounters an allergen, it triggers an immune system response. An excessive immune system response to an allergen is called an allergic reaction. Occasionally, there is a severe life-threatening anaphylactic reaction. Pathophysiology of allergic reaction: an excessive response to an allergen is an allergic reaction. A severe systemic immune response to an allergen is called an anaphylactic reaction. Chemicals released by the body in anaphylaxis cause airway swelling, bronchoconstriction, and vasodilation. Sensitization: on first exposure to an allergen, sensitization occurs and IgE is produced. After sensitization, IgE antibodies attach to two types of immune cells: mast cells in the tissues and basophils in the blood. On subsequent exposure to an allergen, the allergen attaches to IgE. Mast cells and basophils release chemicals that mediate the events of anaphylaxis. The primary chemical mediator is histamine. So here we go: life-threatening responses in anaphylactic reaction: bronchoconstriction, capillary permeability, vasodilation, and an increase in mucus production. So what we see in this picture, in this figure, we see bronchoconstriction, capillary permeability, and vasodilation. So if you look right there, it says normal bronchial and then constricted bronchial, where it's the smooth muscles have constricted the bronchial, closing off the airway, which leads to acute respiratory compromise. Could be an occluded upper airway with labor respirations, if that's the case. Capillary permeability: H2O is leaving the capillaries, or you can have normal bronchioles and then edema of the bronchioles, where that's swelling of the bronchioles from that permeability, and then vasodilation. You see right there the normal vessel and the dilated vessel, which could lead to acute circulatory compromise, which is a failing blood pressure, weak pulse, poor tissue perfusion. Anaphylactoid reaction, or non-IgE mediated. An anaphylactoid reaction does not involve IgE, but the signs, symptoms, and treatment are the same as for anaphylaxis. The causes for anaphylactic and anaphylactoid reaction: allergens may enter the body through injection, ingestion, inhalation, and contact. The common types of allergens include antibodies like penicillin, vancomycin, Bactrim, sulfatrim, those types of medications. Local anesthetics like procaine, lidocaine, tetracaine, benzocaine, and novocaine. Opiate drugs, or opiates in period. Hormones. Steroids, vitamins, angiotensin converting enzyme inhibitors or ACE inhibitors, aspirin, non-steroidal inflammatory drugs or NSAIDs, radiographic iodine-based dyes, protamine, polysaccharides, skin creams and cosmetics, vaccines, blood transfusions, foods like peanuts, nuts, eggs, shellfish, whitefish, wheat, soybeans, red dye sulfate additives, insects. There's a whole list of insects right there. Marine life, mammal bites, environmental, mold, pollen, cold, latex, perfumes, exercise, and idiopathic, which is unknown. Click on the problem below that is responsible for decreased perfusion related to the effects of histamine and anaphylactic reactions. So if you chose C, you are correct. Several factors lead to decreased delivery of oxygen to the tissues in anaphylaxis. Among these are hypotension from vasodilation and loss of fluids from vascular space, and decreased ventilation from airway swelling and bronchoconstriction. You're seeing size up. Anaphylactic reaction is often apparent because of the characteristic signs and symptoms. In the scene size up, be aware of dangers such as wasps and bees. You don't want to become patient number 2. The type of setting and medications at the scene can provide clues. During your primary, get a general impression, but it may be malaise, like just really bad, general discomfort, or sense of impending doom. Mental status may be alert to unresponsive, high risk of airway obstruction, stridor, crowing, indicate upper airway swelling. Airway adjuncts will not help laryngeal edema. Laryngeal edema is the swelling of the larynx. Okay. Wheezing may be prominent. Positive pressure ventilation may be needed. Maintain the SpO2 of 94% or greater. Ventilations may be difficult from increased airway resistance. Consider ALS airway management. The pulse may be weak and rapid. There may be edema, and the skin may be red and warm or cyanotic. Hives and itching are characteristic. There you go. Localized angioedema to the tongue from anaphylactic reaction. Hives or urticaria from an allergic reaction to a penicillin-derivative drug. Hives from a food allergy. Assessment-based approach to anaphylactic reaction. Primary assessment signs and symptoms include rhinitis, tachycardia, pruritus, and faintness. Warm, flushed skin. It may be pale as well. Agitation, anxiety, urticaria, and edema. Be prepared for immediate intervention and transport. Determine whether the patient has an epinephrine auto-injector. Okay, so here's the description of some of those signs and symptoms. Rhinitis, nasal congestion, itchy nose, sneezing, swollen nasal mucosa and runny nose. And that's why on the right, all the way to the right, pathophysiology is what causes it. Laryngeal edema, increased bronchial airway resistance, and cardiovascular collapse and poor perfusion. So these are some of the things you need to look at and read and understand and know. Some more. Your secondary assessment for the history of the present illness, use OPQRST, onset, provocation, quality, radiation, severity, and time. Time is critical. Generally, the more quickly the reaction develops, the more severe it will be. Determine the following. Are the signs and symptoms consistent with anaphylaxis? Are signs and symptoms mild, moderate, or severe? Are signs and symptoms getting worse or better? Does the patient have a history of allergies or anaphylactic reaction? Is an epinephrine auto-injector prescribed? Any other medications taken? What medications is the patient taking? And are there any new medications? Sometimes when people change their medications or the doctor changes it, they find themselves having a anaphylactic reaction because maybe that type of medication will cause it. They're allergic to it. So, has the patient had an anaphylactic reaction in the past? How severe was the last reaction? And does the patient have other illnesses? When did the patient last eat or drink? What did he recently eat or drink? Activities prior to onset of the reaction. Was the patient exposed to anything that could have caused the reaction? Secondary assessment, signs and symptoms. Look at the skin. Check the respiratory system. Use your stethoscope, please. Cardiovascular system, central nervous system, gastrointestinal and genitourinary systems, generalized signs and symptoms. So when you examine people, you need to check just all the other symptoms too, not just the ones that you may see that are infected right away. Obtain a baseline set of vitals. Hypotension may be present. Respirations may be fast and labored. Wheezing may be heard without a stethoscope. The pulse may be rapid and weak. Distinguish between a systemic and a local reaction. A systemic means the entire body system is involved. The local is just going to be in that area where, like if they were stung or something like that. Treatment depends on this distinction. Two key categories of signs and symptoms: airway and respiratory compromise, and shock. So these are going to be your two key categories. Make sure we get a patent airway, because without an airway, it's going to be bad. And then if we don't have an airway, also be thinking about shock as well. The body's going to start shutting down. Indicators of a severe systemic anaphylactic reaction. Acute onset means come on quick, minutes to several hours, with involvement of skin, mucosal tissue, or both. Hives, itching, flushing, redness, edema to the face, lips, and tongues. And signs or symptoms of respiratory distress, like dyspnea, wheezing, stridor, and an SpO2 less than 94%. And or signs and symptoms of poor perfusion or hypotension. Your assessment-based approach: emergency medical care, maintain a patent airway. Airway adjuncts may not be effective. Suction secretions, and maintain the SpO2 of 94% or greater. Be prepared to provide positive pressure ventilation. Administer epinephrine by prescribed auto-injector according to protocol. Consider requesting ALS. ALS may be requested because because there may be a need to do an advanced airway like an ET tube and initiate transport early. Now, one thing I want to tell you, and I know it's probably going to get into in just a few minutes, is that epinephrine, although it does work, it is a temporary fix. So we always want to administer epinephrine and be leery that that allergic reaction can come back and we may have to administer it again. During your reassessment, look for indications of a mild or moderate reaction is progressing. Monitor the effects of treatment. Closely monitor airway, breathing, oxygenation, and circulation. Reassess the vital signs. Biphasic anaphylactic reaction is 20% of patients experiencing an anaphylactic reaction have a biphasic or late stage reaction. So if I'm allergic to peanuts and I eat something with peanuts in it, I'll have a very late stage, if it's a biphasic, a late stage reaction to it. Your summary for assessment and care: recognition and prompt treatment of allergic reaction are critical to positive outcomes. Okay, epinephrine auto-injector. Epinephrine mimics the effects of sympathetic nervous system to treat the signs and symptoms of anaphylaxis. Alpha-1 effects causes vasoconstriction. Beta-2 effects cause bronchodilation. And beta-1 effects result in side effects. So let's cover these real quick. Let's see if they got any in the notes here. All right. Epinephrine has 4 properties: alpha-1, alpha-2, Beta 1 and beta 2. Alpha 1 causes the vessels to constrict. Alpha 2 regulates the amount of vasoconstriction. Beta 1 increases the heart rate, force of contraction of the heart, and the speed in which the electrical impulses are carried throughout the heart. Beta 2 causes the bronchial smooth muscles to dilate. 3 major responses to the chemical mediators by the body causing the life-threatening anaphylactic condition are an increase in capillary permeability, vasodilation, and bronchoconstriction, and inflammation. Epinephrine's alpha properties cause vasoconstriction and tighten the capillaries, reversing the vasodilation and increased capillary permeability experienced by the anaphylactic patient. The beta 2 properties cause bronchodilation, reversing the bronchoconstriction. The beta 1 properties are responsible for the side effects for administration. Also, epinephrine has a direct antihistamine effect, reducing the effects of the histamine. Okay. Epinephrine auto-injector. The effects of epinephrine are rapid but short-lived. Auto-injectors may be packed singly or in pairs, and there are two dosages. These are some dosages you need to remember, because you may have to draw up epinephrine in a syringe if you don't have an auto-injector. So for patients 66 pounds or greater, you're going to use 0.3 milligrams. And for patients less than 66, you're going to use 0.15 milligrams. So it's cut in half. Alright, there's an auto-injector. Some of you have already used these and become proficient with them in our skills training. If the patient has more than one auto-injector, transport the second device with you, just in case. The dose can be repeated in 5 to 15 minutes if needed. Epinephrine auto-injector side effects: increased heart rate, pale skin, dizziness, chest pain, headache, nausea and vomiting, and excitability and anxiousness. Alright, administer an auto-injector. Always provide oxygen for your respiratory patients, especially those who are in anaphylaxis. Check the Epipen for the make sure it's prescribed to the patient. Check the expiration date and clarity of the drug. Remove the safety cap. Push the injector firmly against the thigh until it activates. Hold it in place until the medication is injected. Immediately place your spent epinephrine auto-injector in a sharps container. Case study conclusion: Luke and Joy quickly gather information to confirm their initial impression of anaphylaxis. Jesse has an epinephrine auto-injector in the nurse's office, but the nurse is not currently at the school. As Joy reassures Jesse and completes a rapid secondary assessment, including vital signs, Luke confirms that the auto-injector is prescribed to Jesse and administers it. Recognizing the short duration of the action of the epinephrine, the EMTs do not spend further time at the scene, but transport immediately. Jesse's wheezing decreases en route, and there are no worsening of his swelling or rash. His blood pressure remains normal, as well as his SpO2, although his heart rate has increased from an initial 104 to 116. At the emergency department, Jesse receives additional epinephrine as well as an antihistamine after being observed and monitored for several hours. Jesse's parents are grateful to be able to take him home. An anaphylactic reaction is a severe allergic reaction. The pathophysiology includes airway edema, bronchoconstriction, and vasodilation. Care includes airway management, ventilation and oxygenation, and administration of epinephrine. Anaphylaxis can progress rapidly. Reassess the patient frequently. Okay, we'll see you next time.